That's just starting now. So the first speaker tonight will be Lynsey Mitchell, a lecturer in law based at Strathclyde University. Welcome, Lynsey. Over to you.
Thank you very much, Georgina. And I'm just gonna share some slides. So hopefully everyone can see that. Can you just tell me that you can see that, Georgina?
Yes, we can see it.
Awesome, right, okay. I've done this before, and there's nothing worse than halfway through it, everyone saying we can't see. Okay, so thanks very much, and hi to everyone who's joining us on this very wet and windy night. I'm Dr. Lynsey Mitchell. I'm an academic in the law school at the University of Strathclyde. I'm predominantly a human rights law researcher, but I have a strong focus on women's rights, and lately I've been involved in a lot of projects looking at reproductive rights. So I was asked to just give a brief overview of what is the legal position in Scotland, because again, for a lot of people who are not legal experts, things can get confusing quite quickly, and it was just to make sure that everyone was using, if not the right terminology, but everyone had at least an awareness of where we were starting from and what some of the technical issues around decriminalisation might be. So I'm going to try and kind of keep this brief. The recording will be available, the PowerPoints will be available. This is not a lecture or anything, but it was just to give people a bit of brief information. So this is actually a bit of a chat about where we are in Scotland and what the law in Scotland says about abortion. But actually, before we can have a look at the law in Scotland, I think it's quite important that we take a quick look at the law in England and Wales, just to give some context here. And the reason for that is that many more people are much more familiar with the law on abortion as it stands in England and Wales. And quite often, unfortunately, if you are reading things online, if you're maybe looking at blogs, if you're just perhaps looking at things in the media, quite often when they are talking about the law, they will actually refer to the law in England and Wales. So just to give everybody a little bit of a refresher, or if you're new to this, in England and Wales, abortion is a criminal offence, and it's criminalised by a piece of legislation called the Offences Against the Persons Act. This is a piece of legislation from 1861, which was passed during the reign of Queen Victoria. So as you can imagine, it's pretty old. It uses some really archaic language. If you look at the original text of this legislation, it actually says that the penalty for procuring abortion is penal servitude, and it talks about people being sent to the colonies. So this is really not the sort of legal framework that anyone would want governing modern healthcare. But just to make people aware that this act only applies in England and Wales. It used to apply in Northern Ireland. That's obviously a whole different circumstance, so we'll not get into that. It has been repealed in respect of Northern Ireland. It still applies in England and Wales. So that is still good law, and we are aware that there are currently women in England and Wales being prosecuted under this legislation. But one thing to note is that this legislation does not and has never applied in Scotland, and often that is one of the mistakes that people often make as a starting point. If they're talking about decriminalising abortion in Scotland, often people will put forward the argument about repealing, which basically just means removing a statute from the book. So people will talk about repealing the Offences Against the Persons Act, which is what the campaign for decriminalisation in England and Wales is all about. However, the situation in Scotland is a bit different. Depending on who you talk to, it's either a little bit simpler or it's a little bit more complex, depending on where you are within the argument. So that's England and Wales. Now to give people just a little bit of context about where we are in Scotland. Again, this will be familiar to most people, but Scotland has its own independent legal system, and even after union with England in 1707, Scotland retained that independent legal system, and you see that quite a lot in Scottish criminal law. So many people are familiar with the fact that, you know, the criminal courts and the criminal system in Scotland is quite different from England. You often hear people in the media in England, they will talk about people being charged with manslaughter or GBH. These are not crimes that exist in Scotland. We would use terms such as culpable homicide or assault. So one of the big differences about the criminal law in Scotland is that we tend to not have pieces of legislation that criminalise certain activities. In Scotland, much of our criminal law is governed by what we refer to as common law. Basically, I mean, you could sit through a 2-hour-long lecture on this. I'm not going to subject anyone to it. So basically, in simple terms, it just means that Parliament hasn't passed legislation. The extent and interpretation of the scope of much of Scotland's criminal law is done by the Scottish courts. So what that means for the criminalisation of abortion is that there is no one piece of legislation or no one piece of statute like there is in England that criminalises abortion. So that both makes things a little bit simpler, but it can also make things a little bit more complex because we can't just point to one piece of legislation and say, let's put it in the bin. So some of the starting point for people who do legal research or who are interested in legal history is to go back and look at some of the historical cases of abortion in Scots law. So I dug out a couple and I had a look. And one of the things that becomes clear is that I think even some of the eminent legal professors of the day, these were obviously all men. So I'm not entirely convinced that abortion was something that was really on their radar. There isn't a lot written about it. But one of the first recorded cases of abortion as a crime in Scotland is a man called John Fenton, who was prosecuted in 1761. And there is reference in some of the sort of eminent criminal scholars of the day from the sort of 18th and 19th century. One of them referred to abortion being tried as murder in 1627. Now, we don't know the facts or the circumstances of any of this. So it's very difficult to say anything other than the fact that there were historical prosecutions. So it was quite clear that the common law in Scotland did historically view abortion as a crime. And I think it's probably fair to say it still does. Where things get a little bit complicated though, is that, with the rise of medicine and modern science, once we got to the 19th and 20th centuries, and abortion very much became something that, male doctors were becoming involved in. There is a view among certain people, certain legal scholars in Scotland, but previously amongst the medical profession as well, there was a view that Scotland did not criminalise abortion, and that prior to 1967, it was not a crime for a doctor to carry out an abortion if that was what the woman wanted. So, for instance, the famous gynaecologist Sir Dougal Baird, he claimed in 1975 that abortion had never been a crime and that he had provided abortions in Scotland over a period of 30 years and happily did so, convinced that he was not engaged in criminal activity. There's also various historical records that show that abortions were carried out, some abortions were carried out in the NHS in Scotland prior to 1967. Now, again, we don't know the circumstances. We don't know if these are women who were already miscarrying. We don't know if this was to save people's lives. So there's very little that we can say on this at the moment, or certainly that I can say on this. But this was the view, certainly, of some of the eminent legal scholars and some of the leading medical doctors of the day, that it was a mistake. And anyone who thought abortion was a crime in Scotland prior to 1967 was confusing themselves with the position in England. And one of the leading legal encyclopedias stated in 1936 that a therapeutic abortion was not a crime in Scotland and would not be charged as a crime unless the provider displayed criminal intent. And this is one of the sort of legal standards we use in criminal law. So for the prosecution to occur, the Crown would have to prove a wicked and felonious intent. So basically what they're saying here is that the law, the common law, would be able to tell the difference between someone who attacked a pregnant woman and caused her to lose her baby versus a doctor who was providing a therapeutic abortion. One of those could be criminal and one would not. So this is where a lot of the very historical legal debate is. You might think, well, why are you telling us any of that? I'm telling people this basically just to say that one of the biggest objections when we talk about decriminalising abortion in Scotland is that often an automatic response that we get is that people will say, actually, did you know that abortion is not actually a crime in Scotland, Lynsey? So this is something that comes up and again. My personal opinion, and I'm probably not the leading authority on the matter, but my personal opinion is I'm not sure any of that legal debate actually matters. What we do know for certain is that in 1967, correctly or incorrectly, the Abortion Act was passed by the Westminster Parliament. It applies in England, Wales and Scotland. And if you have a look at the legislation, the way it is worded, it makes very clear that it considered abortion to be a crime in Scotland, in England and Wales. The Abortion Act obviously still applies. It's good law in Scotland. And the Abortion Act says, it states quite clearly in section 5.2 that any abortion that is carried out with the strict parameters set out in the Abortion Act remains a criminal activity. So this is the framework that we have to work with. So I'm often not convinced about some of the value of looking at, what sort of old men previously said. However, when it comes to law, that is something that, we spend a lot of time looking at and reading. So there is a lot of precedent there. There are arguments to be made around Scotland's common law. I think, though, that we cannot get away from the fact that at the moment, abortion in Scotland is governed by the 1967 Abortion Act, and it makes clear that an abortion that takes place out with the framework set out in the Act is a criminal activity. And what's more, in the Supreme Court said in the case of Dugan, which was the case brought by the Glasgow midwives that some people will be familiar with, in 2014, the judges in that case, they were of the opinion that abortion was criminal in Scotland and remained a criminal activity if it took place, again, out with the parameters of the Abortion Act. So the Abortion Act is this constricting framework, and I'm sure this is something that Audrey will talk about in much more detail about her personal experience. But I'm sure, as many of you know, it requires the permission of 2 doctors, and it said that abortion has to be carried out on medical premises, and anything that deviates from that is potentially criminal. And this operates as a bit of a straitjacket. So, for instance, in 2017, when the Scottish Government amended the regulations that allowing women's homes to be classified as an approved place so as to conform with the Abortion Act and allow women to take the second abortion pill in their homes, this was immediately challenged in the courts by SPUC Scotland. They lost the case, but again, they appealed, so this had to go to court again. So legal challenges are really time consuming, they're really expensive, and this creates delays. So this couldn't be rolled out until we had a judgment from the courts saying that the Scottish Government did have the power to approve a woman's home as a place to take pills. That would mean, therefore, if she took the second pill at home, it was not criminal, and therefore that fit within the constraints of the Abortion Act. And again, during COVID, again, when the Scottish Government put in place temporary measures to allow women to take both pills at home, it made very clear that it was doing so just as a temporary basis for the pandemic. And I think one of the reasons behind that was that they were very much worried that anti-choice groups would bring a legal challenge. And I think people were really worried that, you know, we would struggle with abortion provision during the pandemic at all then. So one of the big things about the Abortion Act and the framework around it is just how constricting it is. I'm sure Audrey will speak in more detail about this, and the fact that how abortions happened in 1967 is obviously very different from how they are now. But the fact is, the way that the legislation is written, even if you want to change something because it will benefit women, even if something is now good practice or it makes things better, if it doesn't fit within the narrow terms of the Abortion Act, basically it is still a crime. So this is why we talk about decriminalisation, and this is what we mean. We are talking about removing this criminality, this criminal framework from abortion. So I'm often asked, you know, well, why does this matter? Why would we bother? You know, if we're not even sure abortion is a crime in Scotland, if prosecution is unlikely. And what I would say to people, just quickly to finish off, is that just because certain laws are not being enforced at any point in time, it doesn't mean that they won't be enforced in future. So again, if you look at England and Wales, previously, if you look at Northern Ireland over the last 10 years, there hadn't been prosecutions for abortion. And then all of a sudden, in the last 5 or so years, we see women in England and Wales, we saw women in Northern Ireland being prosecuted for procuring their own abortions. So who's to say, you know, we've seen what's happened in America, who's to say that this cannot happen in Scotland? So it would be better to clarify the law. Another point just to quickly make as well, that although this is very, very rare, it is possible to bring a private prosecution in Scotland. And again, we know that anti-choice groups are very well funded. We know that they are happy to use the courts to frustrate abortion care. So there is always the possibility that they would fund a private prosecution, even if the Crown Office took a view that, you know, it was not interested in pursuing a prosecution. There is always the possibility that an anti-choice group might do that. So I think these are some of the reasons why it makes sense that we want to think about decriminalisation. We want to think about removing those criminal penalties. And what we're saying is that abortion is no longer a crime. It would be a wholly medical matter. It puts patients first, and it allows doctors to provide health care. What we do not mean is that we are not saying about deregulating abortion. All we are simply saying is that there would be no criminal penalties. So in the same way that, you know, lots of healthcare is very, very highly regulated and it's all about patient safety, in the same way with abortion, that would remain the case, but there wouldn't be these criminal penalties or sanctions overhanging how abortion care providers carry out their job and how, you know, women have to undergo their abortions. And just finally, to sort of finish off, it's worth pointing out that many countries across the world, I didn't have time to provide the full list, but many countries have already decriminalised abortion. And usually the statistics and the evidence that comes back from these countries is that it's actually better. Usually the evidence suggests that this allows women to access abortions quicker. So there's quite a lot of support for decriminalising abortion internationally. And I think it's quite important that, you know, if Scotland and the UK as a whole, if we see ourselves as, you know, people who care about women's reproductive health, then, you know, I do think we need to move with the times, and, you know, we need to sort of follow the footsteps of other countries who are rapidly overtaking us and how they regulate abortion within the law. So that was just, hopefully people found that helpful. Obviously, I'm happy to take any questions for anyone later. And as I said, the slides and stuff will be made available. So I'll stop the screen share now and I'll hand back to Georgina.
Hi, sorry, that's great. Thank you, Lynsey. So our next speaker is Audrey Brown, an abortion care doctor and chair of the Scottish Abortion Care Providers Network. Over to you, Audrey.
Thanks, Georgina, and thank you for the invitation to speak this evening. So as Georgina says, I'm a doctor working in abortion care. I've been providing abortion care in NHS Scotland for over 30 years. And I currently lead the abortion care service at Sandyford in Glasgow. I also chair the Abortion Care Providers Network in Scotland, which brings together clinicians working across Scotland, providing healthcare. Lynsey's talk was absolutely brilliant, and even as someone working in abortion care, it's really good to just remind us about that background to abortion law and how that currently sits. I was sort of laughing to myself when Lynsey mentioned historically about old men sort of pontificating around abortion law and abortion rights, and unfortunately those old men haven't gone away, and I think we can all think of older men who are currently interfering in abortion provision in Scotland. So what I wanted to do was take you through really a journey which covers patients and abortion care providers' experience of working with the abortion law as it stands in Scotland. What I think you'll find is that this shows that the abortion law currently is very frustrating for staff and patients. It delays treatments. It causes unnecessary demands on staffing. There are the risks of prosecution and the stress that can bring. And it can also sometimes be used as a tool to delay people's access into abortion care. So I'm going to illustrate a number of points with sort of patient stories. One of the things I want to look at is how the requirement for the 2 doctors' signatures can impact on care. I want to show you how the Abortion Act is used to very much limit the role of other healthcare providers like nurses and midwives in healthcare. Also, the Abortion Act restricts the location of where an abortion can take place. Even although there have been some changes recently around medical abortion medications, there are still restrictions on where mifepristone, the first abortion drug, can be taken. And I also want to show you that actually the abortion law as it stands in Scotland discriminates against women who have an abortion request. So the first person I'm going to talk about is a 25-year-old woman. She's come in to a clinic for an abortion consultation. She's seen one of her doctors in the clinic. They've had quite a detailed discussion about her situation. The doctors carried out a scan. She wasn't sure how far on in the pregnancy she was, and the woman turns out to be 12 weeks pregnant. She's unable to continue with this pregnancy. She has a number of personal circumstances that she feels this is not a good time for a pregnancy and she couldn't cope with a pregnancy. Now she is now 12 weeks pregnant, so she doesn't meet the criteria to be able to do a home-based medical abortion. She'll require to do the second part of her medical abortion in the hospital setting. So the doctor that's seen her looks at what availability there is in the hospital. Many of you will be aware that the time interval between the first and second parts of abortion needs to be between 24 and 48 hours. Luckily, there's a space in the ward in about 24 hours' time. The woman is very keen to get ahead with her treatment. She's distressed about being pregnant, and she really wants to proceed to the abortion treatment. However, the clinic that the doctor's working in and the patient has attended only has one doctor on clinic that day. There's another doctor working in the building doing a different task, but that doctor is a conscientious objector and wouldn't wish to participate in any part of the abortion care. So this patient is keen to go ahead with treatment. It's clinically very appropriate, but the doctor only has one signature on the certificate for abortion, their own signature. So what do we do in this situation? We can't proceed to abortion without a second signature. So do we send the woman away and delay her abortion until the next space is available? We look at the ward admissions and realise that the ward's booked for the rest of the week. The next admission is going to be a week away. or does the doctor give the patient the first tablet to take and get the form signed at a later date the following day? Well, that way, going with the law as it currently stands, that would be criminal, because the woman would have started the abortion procedure without the appropriate legal paperwork in place. So technically, both of them would have committed a crime. So the only solution there would be to delay the women's abortion until the appropriate legal paperwork's in place. And of course, we know that whenever you delay an abortion, when abortions become later, risks increase, the woman is more distressed, etc., etc. So removing the need for that medical approval wouldn't put the woman at any additional risk. There'll be clinical protocols, the women will have informed consent, the drugs will be exactly as they are just now, but it'll mean, like as someone could for any medical procedure, the clinician looking after them and the patient make the decision between the two of them and the treatment goes ahead. So the requirement of the two doctor signatures certainly can delay and impede timely care. The second person I want to tell you about is someone who's younger. She's 18. She has come into the abortion care clinic and had a consultation with one of our very experienced abortion care nurses. Our nurses work in a very extended role, so they've done the entire consultation, found out about the woman's situation, her medical history, her needs, etc. The nurse is also trained to do a scan and has done an ultrasound scan confirming that the woman is in early pregnancy. She wishes to do a medical abortion at home and is keen to start that as soon as possible. The nurse has obtained consent from the woman for a medical abortion at home, but we then come to a sticking point. The nurse can go no further. She's able to provide really quite an extensive consultation and care package, but she can't proceed any further because she doesn't have two signatures from doctors. So she's then placed in the situation of, if she's working in a large clinic or in a hospital, running around the hospital, trying to find someone who can come and see the woman, provide a signature, etc. Now, we know from previous research about people accessing abortion care, one of the things that they find distressing and upsetting is having to repeatedly tell their story to different people, having to justify their decision to different people, and that stress of we're trying to find someone to sign a certificate to give you permission to get an abortion it is not a good situation for someone to be in. It's stigmatizing, they feel vulnerable, they feel unconfident that they're going to be able to get an abortion. The other issue that arises is without the medical input there is no prescription for the abortion care drugs, which does seem quite ridiculous. Many nurses now are non-medical prescribers, so they're trained and qualified to prescribe a wide range of medicines. Nurses can prescribe drugs for cardiac drugs for heart disease. They can prescribe controlled drugs, including morphine, diamorphine, etc. But they are not allowed to prescribe mifepristone, the first drug in the abortion medical abortion package. Now, there's probably very few drugs that are actually as safe as mifepristone to take. Mifepristone's deemed by the World Health Organization to be an essential medicine, which saves people's lives, but nurse prescribers are not allowed to prescribe it. So again, the Abortion Act is really very much limiting the role that nurses and midwives can actually play in abortion care. It seems really to set back nursing and midwifery practice. So we'll move on to case 3, which focuses on the location of abortion and where that can take place. So this woman is 29. She does a telemedicine abortion consultation with our service. She has phoned in, she's spoken to one of our doctors or nurses on the phone. She's absolutely sure of her decision, and she's early in pregnancy and she wants to do an early medical abortion at home. As Lynsey mentioned, in 2017, excuse me, the law was amended to allow women to take misoprostol, the second tablet, at home. But at the start of the pandemic, there was a further change to allow women to take both parts of medical abortion at home, as long as they met certain criteria. So this patient meets the criteria to be able to do an early medical abortion at home. However, as part of the consultation and discussing her reasons for abortion, she's explained that she is unfortunately living with a very controlling partner. She's in the process of trying to move on from that relationship, but hasn't yet managed to do that. She knows that if her partner finds out that she's pregnant, he will absolutely force her to continue with the pregnancy. So she doesn't want to do that. She's very sure she wants to go ahead and have an abortion. It doesn't suit her to have the medicine pack delivered to her house, either by post or by courier, because, as I say, the partner's very controlling. She fears that he would open the pack, he would destroy the medicine, etc. So she comes up with a plan that she wants to collect the medicine pack from the clinic and then take it to her friend's house. Her friend knows about the situation, her friend's trying to support her to be able to escape the relationship, and she wants to do the medical abortion at her friend's house with the support of her friend and distant from the partner. However, the law doesn't allow her to do that. The law around early medical abortion at home only allows the abortion to take place in the patient's place of residence. So we're then faced with a further choice. Does she take the medical abortion pack and hide it in her house? But then there's a risk of him finding out. If he finds the medicine, she thinks he'll destroy them and not allow her out. She'll be forced to continue with the pregnancy. Does she go into hospital? We could organise for her to go into hospital and do the medical abortion. That would be a legal place for her to do her abortion, but that would mean a delay until we can get a hospital bed organised. It means she's got a further journey to be able to travel to hospital. He limits her finances, so she's not sure she would be able to afford that extra journey to get to hospital. Or do we just turn a blind eye to the fact that she's already told me that she's going to take the medicine pack to her friend's house and do it there, but then of course she would be committing a crime, carrying out an abortion in a place that's not approved, and I guess I would be a party to that crime if I knew it was taking place. So the law, although it has improved over the past few years on place of abortion, it currently is still very limiting, particularly for people in difficult circumstances. The same could apply, we have seen this on occasion, that perhaps someone who's a student studying in England and they're registered for healthcare at their place of study, they've become pregnant and they've had a consultation with one of the abortion providers in England and have received an abortion, medical abortion care pack, either by post or collected it from the clinic. The young student then confided in her mum, who said, oh, come back up for the weekend, I'll help you through this, I'll support you, etc. So the student pops her medical abortion pack in her bag and travels to Scotland to do her treatment at home with the support of her parents. But again, that is not permitted by law. Women who are living in Scotland can have medical abortion at home provided by prescribers in Scotland, but it would not be permitted for someone to be prescribed drugs for use in England and then to move to another country to do the treatment. And the same would happen vice versa. If I provided a medical abortion pack to a student studying in Glasgow who then took the pack back to her parents in Liverpool, for example, that would not be compliant with the law. So the other challenge that I want to touch on follows on from that, and it's really restrictions around where someone can take the mifepristone, the first part of medical abortion. This is a 34-year-old woman who's contacted the clinic. She knows that she's 9 weeks pregnant. She actually lives in a more rural area, and it's about a 2-hour journey from her home into the hospital in Glasgow. So she's 9 weeks pregnant. She wants to have her abortion done in the hospital setting. She doesn't feel confident about self-managing abortion at home. She's had a miscarriage previously and had quite heavy bleeding, and she would feel much more comfortable doing the second part in the hospital setting. So that's fine. We can organise that for her to come down and go into hospital in a few days' time. But she asks, for the first part of the tablet, I know I need to take that 24 to 48 hours before. So could you post me that tablet up? And that would save me that round trip of at least 4 hours to come to the clinic. And unfortunately, the answer to that is no, because medical abortion at home and the taking of mifepristone at home can only be delivered under the current law as part of an early medical abortion at home package. So this woman, because she wants to do the second part of treatment in hospital, the law as it stands would not permit her to swallow that mifepristone tablet in her home setting. It has to be swallowed in a hospital or a licensed premises. So the woman is then facing a real dilemma. As the clinician, should we just post it to her anyway and maybe nobody would ever know? But that would then be illegal, and none of us want to be in the position of breaking the law. She asks, could she pick it up from her local pharmacy? But again, a pharmacy is not currently deemed an appropriate place to get a medical abortion tablet. So the woman then thinks, well, should I just do the home abortion anyway? It wasn't her first choice, but that's perhaps what she wants to do. The irony then being, if she did decide to do that, I could post her the whole medical abortion package. So I could then post her the first tablet, the second tablet, pain relief to use along with her treatment, etc. But I wouldn't currently be allowed to send her the first tablet for abortion. Or, as happened in the end, the woman made a journey to the clinic in Glasgow, 2 hours each way on a bus with 2 children under 5, for one of our staff to say, hello, here's your tablet, which she swallowed and then went back home again on the next bus. So although place of medical abortion has improved, it's not working very well for all patients. And then finally, I wanted to touch on how the law as it currently stands for abortion discriminates against women who have a pregnancy that they wish to terminate. So I'll example this by a scenario of 2 women who are attending the early pregnancy unit. So these are 2 women who've had bleeding in early pregnancy, let's say about 6 weeks pregnant. They both had a scan done. It's uncertain how the pregnancies are going to proceed. And as would be usual, the early pregnancy unit then arranges for them to come back the following week for a further scan. So woman A, let's say, she returns the following week. She has a rescan done. She's continued to have a bit of bleeding, and the scan shows that the pregnancy has actually stopped developing. So she's had what you may term an early pregnancy failure, which would then go on and become a miscarriage. So the midwife that's seeing her at the early pregnancy unit offers her condolences for the pregnancy not continuing. She discusses the options for management. There's a possibility of just waiting on a miscarriage. There's a possibility of using the same medication as medical abortion to induce a miscarriage, or she could have a surgical procedure carried out. The woman doesn't want to have a procedure carried out in hospital. She's keen to manage her miscarriage at home, and she would like the miscarriage to be induced as soon as possible. So the midwife is able to support that choice. She's able to prescribe the medicines that are required for inducing the miscarriage. Those medicines are mifepristone and misoprostol, exactly the same as we'd use for abortion. And the woman leaves that day with her treatment and goes home to miscarry over the next day or two in the comfort of her own home. Woman B, again, she comes for her rescan. Her scan shows that her pregnancy has continued. She's about 7 weeks pregnant. The difference is that her scan has a so-called fetal heartbeat, as it would be called, which is really a pulsatile movement, but her pregnancy is viable. She explains to the midwife that's seeing her that there's absolutely no way she can continue with the pregnancy. She'd really hoped it would be a miscarriage. She's already got 3 young children and couldn't possibly take on any more. Unfortunately, the midwife can't help her. The midwife isn't allowed to prescribe mifepristone and misoprostol to cause an early medical abortion. And the only way for her to get an abortion is to then be referred into the abortion service. So this results in a delay until the woman gets an appointment at the abortion service. She goes there, she has to repeat her story again and explain about the 3 young children and her inability to cope. And she then requires to have her medicines prescribed, exactly the same medicines as Women A, but hers need to be prescribed by a doctor, and 2 doctors need to sign a certificate to give her permission to have an abortion. So really, the Abortion Act, to women in early pregnancy, they're not able to be given an equal choice of options, and a midwife can prescribe treatment for one woman but not for the other woman, and that is solely because one woman's scan had some cardiac activity and the other ones didn't. Equally well, Woman B, who had the viable pregnancy, if she was then happy with that and she decided she was going to continue the pregnancy, then she would go on to antenatal care. She could be looked after throughout her entire pregnancy by midwives. She could have her baby delivered by midwives. There would be no requirement necessarily for any medical involvement. Everyone accepts her choice and everyone supports her choice, and she doesn't need any permission to go ahead and have a baby and be responsible for a child for the next 16 years. But if Woman B wants an abortion, she needs to get a certificate signed by 2 doctors to give her permission. She needs a doctor's prescription and she needs a further consultation. So I think hopefully that journey through those cases would demonstrate to you that there's numerous situations where the abortion law actually inhibits person-centred and modern care. It discriminates against people who wish to terminate their pregnancy. And I certainly think it's time that abortion law needs to be modernised for care appropriate to this day and age. And that view is shared by really all the professional bodies that are involved in care of pregnant women. So the Royal College of Obstetricians and Gynecologists, Faculty of Sexual and Reproductive Health, Royal College of Nursing and the Royal College of Midwives are the professional bodies that govern people providing abortion care, and they all support decriminalisation. Thank you.
Thanks very much, Audrey. No, that was really interesting. So I would now like to ask Alice Mumford from Engender to speak. Thank you.
Thanks so much, Georgina, and thank you to Lynsey and Audrey. That's been just absolutely brilliant. And I'm not going to speak for too long because I want to hear more from you, really. But Engender are Scotland's feminist policy and advocacy organisation, and so we work to advance women's equality in all sorts of different areas, from public transport through to healthcare, of course, which is one of the reasons we talk so much about abortion. And because it is a keystone feminist demand, it's really at the heart of women's rights, to allow women rights over their own body, over their own life choices, and over their own healthcare and well-being. And so decriminalisation is something we've been calling for, along with Abortion Rights Scotland, for a very long time. And often that conversation can turn into, and Lynsey touched on this, but why bother pushing for decriminalisation? It's not really a problem. That the myths around it not even really being criminalised. And it can be seen as an either or. So it can be seen as saying, well, either we should talk about decriminalisation or we should talk about improving services. And you know, and we know that access to abortion is not great for people in Scotland in many ways. And we've already had a question about people having to walk past protesters. But as Audrey's shown there, is that clearly the law has an impact on this service provision. So it's not an either or. We can't just talk about improving services without examining the legislative underpinning of how we talk about women's reproductive rights and bodily autonomy. Clearly, we need both. And we need to be talking about decriminalisation at the moment, because the world is showing us that we cannot be complacent when it comes to abortion rights and women's reproductive rights in general. So we've seen obviously the overturning of Roe versus Wade and the sort of the almost instantaneous attack on women's rights that's come from that, and the reduction in provision. We've seen the prosecutions happening in England and Wales, and of course we've seen decades of this in across the island of Ireland, in women being criminalised, stigmatised, and attacked for trying to have some sort of say over the timing and size and manner of their families and their lives. But we also need to be talking about it now, because there is chance for change, and it's that's a nice way to be talking about it, in that we think there is hope, that we can actually make this happen and bring about those changes that Audrey's talking about, bring about that clarity, and by removing it from the legal system and making it purely in healthcare that Lynsey talked about. And in Scotland, services are improving. We've seen the move to telemedical abortion, we've seen movement on buffer zones. We're not there yet, and globally, the trend is towards better abortion provision. You wouldn't think that from looking at the news necessarily, but actually we've got papers, and I can share them in the chat and in the email that goes out afterwards, that show that globally the trend is towards women's reproductive rights. It's towards better services, it's towards removing abortion from the criminal justice system. And that's great, and we should be not just part of that movement, we should be at the forefront of that movement, in saying that actually this is a fundamental women's right, and we're going to remove it from the criminal justice system. One thing that's often tricky, and one of the things I was asked to talk about, is where political parties in Scotland stand on this issue, and so where are the levers for change? How likely are we going to get this through? And it's quite difficult to know. We know that the public in Scotland is pro women's rights to choose, and pro-abortion. And we don't know a huge amount about politicians, and that's partly because the work hasn't been done in terms of the intensive polling that's needed, and public, you know, and surveying of politicians. But it's also because historically parties have been quite cowardly in talking about this. It's been an issue that has often been left up to, you know, individual politicians and MSPs being given a free vote on this. It's maybe been something that parties say, well, yes, of course, in principle, but we get a bit icky when we're talking about the details because we're women, and it's seen as a polarizing issue. And actually, again, if we look at public opinion, it's not necessarily that polarizing. So it's sometimes difficult to know where parties and even individual politicians stand on this. But again, that is something that's changing. And I think that's one of the very few positives we can see from things like the crackdown on abortion rights in the US. So we've seen a sort of emboldening from people of talking about this. So both in the US, certainly if you spend time on Twitter and things, you'll see a shift from people saying, well, of course, women should be able to access abortion. I'm pro-choice. In extreme circumstances or in these cases, and that's something we hear again and again. And it goes back to what Lynsey's talking about with the law. Fatal fetal abnormality, health of the mother in cases of rape and incest, and conversation is often sat in that sphere of like, if a woman really needs the abortion, if something terrible's happened, she should be able to access that. To actually now people saying, no, I'm pro-abortion. I'm not just pro-choice, I'm pro-abortion. It's a good thing. It can liberate women. It can be good for society. And this is absolutely a thing that we should be proudly saying. Many, many women in Scotland access, and others who can become pregnant access in Scotland. This is a thing that can have a positive impact on people's lives. The most common emotion people feel after accessing an abortion is relief. And we shouldn't be talking about it as this thing that happens in extremis. And we're seeing that with political parties as well. So we've got a motion coming to SNP conference this weekend, which affirms abortion as a fundamental human right, as well as talking about those services. Again, saying we need to attack this from both sides. We need to improve the experience of women and other pregnant people accessing these services. But underpinning that, we need to say, this is a human right. This is an issue of women's rights. This needs to sit within healthcare and not within criminal justice. Similarly, we've seen local authorities reaffirming commitment to women's rights, saying that they want to be the test cases for buffer zones, and that sort of horror that's happening in the US is making people think, well, that's not what we want here, and actually it's not that far away from happening. So we do need to be open and vehemently supportive of this as an idea. And we're seeing other changes in Scotland that will enable this conversation to happen. We're seeing the incorporation of various UN human rights instruments, and of particular interest to us is the Convention on the Elimination of All Forms of Discrimination Against Women. So the CEDAW Convention, which is coming into Scots law, it's going to be incorporated. And this could be a chance to say, look, we've got this. On the one hand, we're saying we support women's rights, we're incorporating this treaty into Scots law, but on the other hand, we're saying that this fundamental issue of healthcare is actually potentially a prosecutable offence. It just doesn't work. So there are these really exciting opportunities coming. And so I'm really pleased that Engender and Abortion Rights Scotland have been able to sort of pull this together, and that folk are here to talk about this issue, because I really do think that now is the time to be having this conversation and to be bringing about the decriminalisation that I think we've all known for a long time is badly needed in Scotland. So I'm going to finish up there and hand back to Georgina and get to some of your questions. Thanks.
Thanks, Alice. So thanks very much to all our speakers tonight. I think the information's been really interesting and enlightening for a lot of us. So we're now going to move on to consider some of the questions that have come in. So we've got a couple of questions through in advance. So I'm just going to run through those now and see if any of the speakers would like to come in. So one of the questions we have is, where do the speakers think that objections could come from, and how do we best prepare for that? Would anyone like to come in on that?
Do you want me to start, Georgina?
Yeah, if you could, Lynsey. Yeah, that'd be great. Thanks.
And I think, and I'm sure everyone here is familiar with this, this is the campaign for reproductive rights. This is not something that a lot of people have just started doing. This is an ongoing thing. But I think the one thing that is really starting to depress people is not just what's happening in places like America, so we see this roll back, but is the fact that the money that funds what is happening in America is starting to kind of percolate, across Europe and within Scotland. So I think, whereas previously we were able to say, oh, here is a particular group of people within Scottish society who, for whatever reasons, they will never agree with abortion. They're not willing to sort of understand or get on board with it. It's almost for them, it's just an ideological position. I think there is obviously going to be that. There's obviously going to be, the religious conservatives. I think the worry, though, is that with this money, that how much influence then is being bought to encourage ordinary people who generally are in favour of abortion. So I think there's those who traditionally have always been opposed to abortion and have always campaigned against it, and the traditional anti-choice groups. But I think we also need to think about, rather than this just being people who write letters or voice their concern, I think we do need to sort of look at, and this is where the US I think is so important, I think we need to look at some of the tactics. So I think that there will be legal challenges. I think, people will use the law. I think people will use social media. I think they will use, every sort of arsenal that they have. So I think in some ways people who are against decriminalisation will not just be the sort of classic objectors of, of any change in the law in Scotland. You'll get people who say, well, why bother? If you're not if you're not, creating a utopia, why bother doing anything? I think there'll be that. But I think there will be these traditional hardcore anti-choice groups. And I think we really need to kind of worry about how we might see that manifest.
Thanks, Lynsey. I suppose another question that leads into that is, I suppose, is it very likely there's going to be a legal challenge to any changes that we want to bring forward?
Yeah, and I'm conscious of the fact of letting other people speak, but I attended the First Minister's summit on abortion on behalf of abortion rights, and this was one of the things that we discussed, and the politicians there were very open about, and they understood. I don't even think we're talking about this in chances of. I think everyone who is involved in this is very aware there absolutely will be a legal challenge, and then that just frustrates everything. And I think for politicians as well, that creates issues, because it just means that any changes will take so much longer than any ordinary legal changes will, because I think this would go all the way to the Supreme Court. That's incredibly time consuming, but it's also incredibly expensive. And I think that's the sad thing about this. We could be spending money doing other things, but people are going to have to spend an awful lot of money, paying lawyers to take this to court. So I think it's not a case of, what's the likelihood? I mean, this will be challenged.
Yeah, I'll perhaps come in that as well. And Lynsey touched on it earlier when the relatively minor change to allow women to take the second part of abortion at home was challenged. It went to appeal, and that process cost a huge amount of money. It caused a lot of distress and stress for people seeking abortion care and clinicians providing abortion care, that were services going to be able to continue? Were we going to have to reverse plans that we had put in place? So I don't, like Lynsey, I have no doubt that there will be some very big challenges to any legislation to change the Abortion Act in any way. And we've been aware, obviously, over the past few years that there is increasing money coming largely from the US to support anti-choice activity in Scotland and England and Wales as well. So yeah, I do have concerns about that. I think as well, some of the narrative which then follows any discussion around decriminalisation then becomes very, very frightening, very alarmist, and there's then inference that it would just be a complete free-for-all. People would be aborting babies up to the very second before the gasp breath, etc. And of course that's not going to be the case. And I would always take the example of, having your appendix removed because you've got appendicitis doesn't require any law around it. You just have it done because you need it done. But someone wouldn't be allowed to, if you've got a sore tummy, cut you open on a kitchen table and do an appendicectomy, because there's clinical guidance, there's rules, etc. There's protocols around that. Certain people will be allowed to do procedures, other people won't be allowed to do procedures. So I think we need to try and keep control of that. Otherwise people may well be frightened into saying, oh my goodness, if we decriminalise, this will be completely out of control. People will be having awful situations because there's then no control over abortion, which it will be controlled in the way that and overseen in the way that any other medical treatment is.
Yeah, just to come in there, I think that's a really good point, and it's also what we've seen from sort of the anti-equal marriage campaign, like this sort of playbook of extremists. Well, could I marry my dog? Yeah. So what can I, am I just allowed to kill a 3-year-old? No, that's not what that is. So yeah, I think being prepared and knowing that those attacks will come is really important. But that also, when the question was first asked, I was just thinking about the Repeal the 8th campaign in Ireland, which I think is a really, really good model for how to do this. And I know lots of campaigners went over. I was one of them to, you know, to spend some time with that campaign, help out and try and learn from what they were doing. And one of the things they did so incredibly well was personal stories. And that's why I think it's great to hear from Audrey tonight, because it's actually something you don't hear about a lot. You know, we know that abortion is still incredibly stigmatized, and also lots of people don't know what happens in all sorts of medical operations. I also don't know what happens in when you have your appendix taken out. But so yeah, so that sort of lesson from them. But the other reflection that links in with this from the repeal of the 8th is that they had lots of really tough conversations within the coalition of groups doing that about how much they talk about abortion as healthcare, about care, about you know, yeah, something that some women need on some and is a difficult decision, those sorts of things, versus saying my body, my rights. And eventually they went with the sort of softer, we want Ireland to be a caring, you know, nurture people. And they did that because that was what was going to win for them. It was like, we need the result, we need the result. And there were lots of women's groups that were uncomfortable with that because they felt it did play into this idea that abortion is difficult and traumatic, and actually they wanted to be saying no. And I think that's the same with some of these extremist things. Now, obviously, some of them, as you say, no, you know, the way to get unsafe abortions is to make them criminal. That's when you know, that's why we use a coat hanger as a symbol for this. It's not about decriminalizing. But there are also people that say, yes, I should absolutely be able to, you know, there should be no time limits. And I think we've rightfully not talked about time limits because it does get into that messy space. But again, there's that question of saying, well, of course that wouldn't happen, but let's have a philosophical conversation about why we're legislating women's bodies. So I think to maybe not get drawn into that is another good lesson, I suppose, from that, and actually say what's the goal here? It's decrim, and also I think it is a risk. You know, it absolutely is a risk. Not because decriminalisation will mean that women are reporting babies in the streets, but because opening up legislation and conversations means that the right and anti-abortion folk and anti-choice people will attack, and they're good at it. You know, and you know, we will talk that the world is scary and there's money coming in, and shout out to Open Democracy, who are doing lots of really interesting work, like trying to look at where this money is coming from, and I recommend sort of looking at their investigations in this. But it absolutely is a risk, and I think the way we overcome that is being prepared for it as campaigners, knowing where our allies are and making it watertight. There will be litigation, absolutely. And so again, thinking what, like, strategically, how are we doing this? Where's the money coming from? All these things. And that's why it's so important to have these conversations and talk about it. And because we need to be ready when the opportunity comes, like with COVID, that happened. And people, because we'd thought about telemedical abortion, there were already calls to allow women to access abortion at home. It was very obvious, COVID's hit, women cannot get to clinics. Right, let's get this in place. And then it's much easier to make the argument, well, you can't withdraw that now. You've given this ability to women, to medical practitioners. So yeah, I think being ready is the key thing, and yeah, and expecting it and knowing it's going to happen, but there's more of us than there are of them.
That's great. Thanks you guys. That was really good. So we've had another question. Somebody's asking is it true that women are getting sent to England from Scotland for abortions? And if so, why is that? I don't know if Audrey, if you can shed any light on that.
Yes, currently there are a very small number of women who are largely people who are between 20 to 24 weeks pregnant, so up to the legal limit for abortion. Currently, none of the health boards in Scotland are able to provide abortions above 20 weeks for women who are requesting an abortion. I think that the reason for that is there's a particular set of skills, I suppose, that a clinician would need to be able to do an abortion at that stage. It would either be a specific surgical procedure, which would require additional training and skills to be able to do that, or there is a possibility of a medical procedure which requires a pre-treatment procedure to ensure the fetus wouldn't have any signs of life. And currently there isn't anyone in Scotland who is able to provide that care for women seeking an abortion for their own choice. So last year there were around 40 or so women who were between 20 to 24 weeks pregnant who were unable to get care in their own health board, and their NHS board paid for them to access that care through one of the abortion care providers in England. Previously, it was a higher number of women. The numbers have come down over the past few years. I think going back 4 or 5 years, there was probably about 100 women a year had to travel to get care. But even although the numbers are small, that's still 40 or so women that are not currently getting care in NHS Scotland. And I think it's something that was touched upon in the First Minister's Summit earlier in the year, although that wasn't the main topic of the summit. It is something that is under discussion in Scotland. As we've discussed, abortion law is devolved. Government wrote to health boards within the past few months advising that all boards are expected to provide abortion care at least up to 20 weeks, and asking boards to look at how we can work to provide a later abortion service in Scotland. So I think that would likely perhaps be a couple of boards that work together to provide that very specialist care for women across Scotland. And it would require, realistically, at least a couple of doctors to undergo that additional training to be able to provide that care. There's no sense in training one person, because then if they're off, the care can't be provided. So I think it will move forward, but currently it's a gap in service.
Can I just jump in there as well and say that, yeah, I mean, and this is talked about quite a lot, that, you know, women are being sent down to England, and obviously it is shocking. People should be able to access the service they need as close to themselves as they can. But I suppose I just wanted to say that provision for women in the islands and highlands, we see people travelling a really long way to access abortion services, even within Scotland. You know, and if you look at some of the islands and the way the ferries are set up, that's a 3-day visit to get through to Inverness, about getting childcare, about maybe losing income if you're on 0 hours contracts, about all those things. So while rightfully people are talking about women having to go down to England, it is worth highlighting that actually women are having to travel long distances and at cost in various ways within Scotland as well. So I think, again, that's where the principle of abortion needing to be as local as possible is really, really important.
Yeah, absolutely. I couldn't agree more. And obviously the number of people needing earlier abortions is much, much greater than the number of people requiring later abortions. I think, telemedicine has made a huge difference to many of the women in those remote and rural locations. As you say, from the Western Isles previously, you would have had to travel over to Rigmore and Inverness to be seen. Now with telemedicine consultations, as long as someone is suitable for telemedicine, if someone from the Western Isles contacts our clinic, we'll do a telemedicine consultation, and then we send their abortion care pack by recorded delivery to their home. So they should get that within a few days of the consultation. But yeah, absolutely agree. We need to look at making sure that everyone can access care as close to their home and with the minimum disruption possible.
I think it's a good point to raise, though, that in Scotland, obviously the majority of abortions are carried out on the NHS, which is great and something I think we should be really proud of. Obviously, there are a lot of issues that need to be addressed and stuff like that, but I think that is a source of comfort, at least. So another question we have is, would it be a long parliamentary and legal process to decriminalise abortion services here? Which I assume the answer is going to be a yes. As what's the kind of, in terms of, Lynsey, you were talking about other countries that have managed to decriminalise abortion. What can we learn from the way they've gone about doing it?
I mean, I think we can learn various things, but again, obviously lots of different countries have different legal systems, and therefore they have their own sort of pros and cons and how they do it. So often a lot of places, they will simply, a lot of places, so for instance, Australia, they did it state by state. So in some ways that sort of dealt with parts of the more conservative parts of the country, where there was most opposition, where it was done on a state by state basis. And I believe that all the states have now changed the legislation, so it's been decriminalised across Australia. Obviously, for reasons that we all understand, places like Australia and Canada, their original legislation on abortion tends to mimic what you have in England and Wales. A lot of their statutes are basically just a sort of mirror copy of the Offences Against the Persons Act. So for them, often it's quite easy because they can say, well, these are sort of colonialist era legislation, it's not fit for purpose. And it's very difficult to make an argument for keeping that. So in some ways, there's ways there that, it's easier for to do. It'll probably be slightly different in Scotland, but I think what Alice said is absolutely key, that we need to look at how people have done things, not just in the Republic, but the sort of sustained efforts in Northern Ireland about, because abortion provision there has really been the untold story in the UK, and their sort of continued efforts to have, and obviously it's still an ongoing situation there because they don't have provision of care really, but they managed to get decriminalisation through there. So I think it is, as Alice says, it's about trying to network, it's about learning from the work that other people have already done. But obviously we will need a very specific Scottish context, and I think a lot of that will be done by people who work at the Scottish Parliament and draft legislation, and there'll be lots of consultation and lots of people will respond to the consultation. So it will be a sort of drawn out process, but hopefully it's one that we can start to get the ball rolling on.
That's great, thank you. I suppose because we don't have, like you were saying in your speech, we don't have the 1967 Act to the Offences Against the Person Act. But is it worth coordinating with the movement in England to repeal the 67 Act altogether? Because that sounds like that would make it a lot easier if we could just get rid of that whole thing rather than trying to add lots of amendments onto the conditions around abortion. I don't know how possible that is.
I think people are doing that. I think you probably want some sort of UK context. Obviously, we do this with lots of things, people across the UK sort of coordinate, but there will be specific legal differences between, Scotland and England. The problem with simply getting rid of the Abortion Act of 1967 is that, well, that would leave you with, that just leaves abortion as a crime and you don't have the framework. So you have to do both. But yeah, there is an argument of, some people would say, let's just start from the beginning, let's just decriminalise it, and then let the medical profession, as Audrey said, plastic surgery is regulated, getting your appendix out is regulated, dentistry is regulated. We don't need these really old-fashioned pieces of legislation that, put in place these really narrow parameters. And as Audrey said, the requirement for 2 doctors is a real bugbear when it comes to providing care. And often anti-choice groups will say, oh, if you decriminalise abortion, you're removing these safeguards that protect women. And actually, the requirement for 2 doctors in the 1967 Act is not about protecting women. The Act specifically says, and the debates around this were about essentially getting women to change their mind. It was about making clear that they knew how serious this was. And, there was a lot of moral shame and stigma, and that is written into the 1967 Act. So you think even the legislation that permits abortion, actually, when we look at it from today's, how we view things, it's a really misogynistic piece of law. So yeah, I would say, Georgina, we could do with getting rid of that, and we could do with getting rid of the criminal penalties. But this is something that I think we're going to need to have a wider conversation about.
Yeah, and just on that like paternalistic sort of nature and punishing women, again, that's what we're seeing in the US with heartbeat laws. When we see anything about, well, a woman has to have a cooling off period or counselling, or has to see the image of the scan, like really horrific stuff. Like it gives me, like you know, that's the legacy of that, and that's the continuation of that women don't really know their own minds and their own bodies. And yeah, just on the like actually how we do it, I think Lynsey's totally right. We need to be having these conversations with other groups, but also attacking it from all angles. And that's the beauty of, you know, a coalition like the abortion rights movement, is that you've got academics and you've got campaigners and you've got, you know, I'm thinking, I mentioned CEDAW earlier, the UN convention, and that's now being incorporated. And the way that happened was, you know, some campaigns on the ground talking about it, people within Parliament doing the work, and Engender commissioned a legal expert on this to say, look, what does this actually look like? You need an expert in Scots law to say, look, we'll do the work for you, like what would happen? And I think we need that as well to say, you know, yes, is it just deleting these 2 lines? You know, what does that mean? And certainly when we wrote back in 2016, we, you know, Engender wrote a report on abortion, which I'll put the link to. And a lot of that, when we were getting to recommendations, the answer was always the guidance. It was like, actually, this stuff, it already, you know, these medical guidance already exists. So it's about changing that. It's about changing those, those provisions rather than anything actually in law. So yeah, this idea that it would leave a vacuum is, yeah, nonsensical, really.
That's great. Thanks, guys, very much. So I think just one last question. Somebody's just asked, how do we go about supporting clinics, basically, in providing this this vital service in the light of the anti-abortion rallies and the increasing anti-choice activity and intimidation that's going on?
Yeah, I'll maybe speak to that first, having been personally affected by it in my place of work. I think we just cannot allow these people to intimidate women accessing clinics, and to intimidate doctors and nurses providing care. It's just unacceptable in this day and age, and I really don't think it would be accepted or tolerated for any other aspect of healthcare if people went outside a transfusion unit to object about people donating blood and having blood transfusions. That would not be accepted. So why on earth we accept it for abortion care is beyond me. And obviously it's a different issue from what we're talking about just now, but the discussion around buffer zones is obviously very current, and I think my feeling is that there's certainly cross-party support in the Parliament to see this through. It's just very intimidating and upsetting, and I get very annoyed with some of the discourse that's on social media saying that, oh no, well, we're not harassing or intimidating people. If women feel harassed or intimidated, that's their fault. That was not our intention, which is, you know, exactly back to bullying, violence against women, emotional bullying, and it's just unacceptable in any healthcare facility.
That's great. Thank you, Audrey. So I'd like to thank everyone for their time tonight, especially our speakers. Really, really great job. Very interesting and lots of information, I'm sure, for us all to think about and work towards going forward. And as I bring the meeting to a close, I'll just ask each of the speakers to give a final comment. And if we haven't been able to take all the questions, or if anyone thinks of any questions to ask after tonight, this is only the beginning of the conversation, and Abortion Rights Scotland, along with Engender, will be arranging further events in the coming months, so do keep in touch. So Alice, would you like to start off with the closing comments?
Sure. I think just to echo your thanks, really, and to you, Juliana, for chairing. It's been, yeah, I feel like decriminalisation is becoming something that was a bit of a techie conversation into a thing that people are talking about and feels like could actually happen, which is super exciting. And to have people giving up their Thursday evenings to come and talk about it and listen about it is testament to that. So I think just I found it really powerful to hear those 2 elements together. So from Lynsey talking about the legislative history and how that is still having an impact on women's lives, and then Audrey sort of really bringing it home with those stories from women. So I mean, I think I said it when I spoke first, but I'm not naturally always that optimistic, but I do feel like this actually is a thing that could happen, and I feel that both through fear from looking around the world and hope through looking around the world. So yeah, looking forward to future conversations. Thanks.
That's great. Thank you, Alice. Lynsey, can I move to you?
Yeah, although it's kind of hard to follow Alice there. Yeah, I think that was such a sort of awesome note of you know, kind of confidence and optimism rather than, as you say, the sort of usual pessimism. And yeah, just thanks to everyone. It's been so good to have these conversations, and I think that we do see this as a continuing conversation. There's obviously some things that we've not been able to get to or touch on, so yeah, everyone is welcome to come and join the conversation. And obviously thanks to everyone for having us, for having me, and obviously, as always, you know, for Audrey to taking the time and actually, as Alice says, you know, bringing home the reality of this, because I think for so many people it can be a sort of a hypothetical or an ideological discussion, and yet, you know, I think we're talking about people's lives, and often people when they're at such a vulnerable part of their life, and Audrey always kind of makes that point really eloquently. So yeah, thanks to her, thanks to Engender, and thanks to Georgina for doing such an amazing chairing tonight.
Oh, thank you. As you say that, I can't get my mute button to work. Audrey, if you'd like to finish us off, thank you.
Yeah, thanks very much to everyone. It's been a really enjoyable evening and a really enjoyable panel to take part in. I think yeah, I think abortion care and people's abortion journeys they're unnecessarily complicated by the law as it stands. It just shouldn't be necessary. For an aspect of healthcare for a lot of people is very straightforward, it's very safe, and it's very uncomplicated. I think women's rights to choose have been put into the position where they're being controlled by doctors, and I think most doctors actually don't want to have the legal control of that. Most doctors would say it's up to the woman to choose, and why should I have to sign a certificate to give permission? So I think, yeah, I equally feel quite positive about the situation. It is good to hear the discussion taking place in lots of different settings, and for once I do feel optimistic. I think we are on the brink of something, and it's really good to be able to grasp that enthusiasm and hopefully bring lots of people on board with us to really push for a change that will improve women's rights and women's choices in Scotland.
Thank you very much. I'd just like to say thank you to all our speakers again for doing such a wonderful job, and thank you for everyone who has turned up and listened and engaged. It's been really productive, I think. And also thanks again to Engender for making this event possible tonight. So we will send out one email to all of tonight's participants after this, just with information on how to sign up to Abortion Rights Scotland, for information on future events and campaigning that we do. This will include details of meetings that are going to be taking place in Glasgow on Thursday, the 10th of November, and in Edinburgh on Saturday, the 12th of November, and also how to access the link for the recording of this event tonight. So I'd just like to leave by saying, do get involved. Change comes when we organise together, and we look forward to working with everyone in the future. So thank you all very much indeed, and good night.
Bye, thank you.